Good afternoon everyone. Today we have a new series on ABG and we'll be touching the basic aspects of ABG in this lecture. We'll be touching the definitions, various equations, the very fundamentals of metabolic and respiratory acidosis and alkalosis. We'll be seeing the effects of acidosis and alkalosis on various organ systems of our body. We'll see the basic compensation mechanisms in response to the various aspects, and we'll see some examples wherein we'll try to interpret the ABGs fast. So coming to the definitions, we have two terminologies. One is acidosis and alkalosis. Second terminology is acidemia and alkalemia, and they are not interchangeable, they are separate. So what do you mean by acidosis? Acidosis means any process which increases your hydrogen ion or proton. Any process, right, which increases H ions in our extracellular fluid is known as acidosis. There is an equation where there is a relation of pH with H ions. The equation is pH equals to negative log of H ion concentration. This is the first equation we use when we are studying ABG. What does it mean? That pH is inversely related to H ion concentration. So any process which increases my H ion in our body will decrease the pH, right? So any process which increases the H ions concentration will decrease the pH, and this decrease of pH is known as acidemia. So acidosis is a process, the outcome is acidemia. Similarly, the decrease in H ions is known as alkalosis. Any process which decreases your H ion concentration is alkalosis. So the resultant feature will be an increase in pH. Increase in pH is known as alkalemia. Okay, it is alkalemia, right? So please always remember this fundamental difference between acidosis, acidemia, alkalosis and alkalemia. Before going to the metabolic and respiratory acidosis and alkalosis, we'll just see in brief why this topic is important for a clinician. Why we want to learn about acidosis and alkalosis, or why do you want to learn about acidemia or alkalemia? So what are the different effects of these processes on our body system? Say for example, we take CNS. Whenever you have an acidic environment in our neuronal cells, you tend to have altered mental status, or you can have coma even if the acidosis is severe. So patient will be having altered mental status and patient can present to you in coma. So that is the importance of doing an ABG in a comatose patient when he comes to you in ER, right? In alkalosis, conventionally our mind thinks that it should be opposite. It's not. Again, patient may come to you with altered mental status, and alkalosis is a very potent stimulation for neuronal irritation. So patient can come to you with seizure. So anyone who comes to you with seizure in ER may be a potential person who has alkalosis, maybe respiratory, maybe metabolic, right? If we talk about CVS, cardiovascular system, acidosis affects our myocardial contractility. So your cardiac output decreases. If your cardiac output decreases, what happens? Your stroke volume decreases. If your stroke volume is less, your output will decrease. So in a given scenario, acidosis will decrease your blood pressure or mean arterial pressure. acidosis is also a very potent stimulator for arterial vasodilation. So total peripheral resistance also decreases. So you have decreased mean arterial pressure and decreased total peripheral resistance. So the outcome is low blood pressure or even shock. One point to be noted that this shock is refractory to your pressor therapy. A person who is presenting you in a profound shock, not responding to vasopressor therapy, probably has acidosis, which is profound. So you correct the acidosis, and then probably your fluid therapy and your pressure therapy will work. Similarly, in alkalosis, it doesn't have any profound effect on cardiac output, but your total peripheral resistance, it increases. So net result is your blood pressure increases. Acidosis and alkalosis, they are also myocardial irritants. So you can have some reentrant tachycardias such as VTAC in acidosis. Alkalosis is more irritant to your heart muscles. You can have SVT, VTAC and even VFib in profound alkalosis. We have a general perception that alkalosis is safer. It is not. You can see alkalosis can cause seizures. It can cause more profound arrhythmias as compared to acidosis. Then you can see the metabolic effects. Metabolic effects. In a cell, you have potassium inside. Potassium is a intracellular cation. When you have abundant hydrogen ions in ECF, they want to go into the cell. So there is a pump which pushes potassium out. So the more hydrogen ion is there in extracellular fluid, by its concentration gradient, it will try to go inside the cell, and there is a pump which pushes potassium out with every proton. So that is the reason of hyperkalemia in acidosis. And this hyperkalemia can be detrimental, right? You can have very bad arrhythmias. Similarly, in alkalosis, your hydrogen ions are less. If your hydrogen ions are less in extracellular fluid, so your potassium will be lesser. So you have hypokalemia in alkalosis. The same mechanism applies for magnesium. In magnesium, the same principle applies. Lesser the hydrogen ions in the extracellular fluid, lesser would be the magnesium. So you have hypomagnesemia in alkalosis. Lastly, albumin. Albumin is a negatively charged substance. It has multiple negative charges. So it bounds to protons. It bounds to hydrogen ions. Multiple negative charges are there. The moment you have alkalosis, by definition it means lesser hydrogen ions. So what will bind to those negative terminals? Ionized calcium. And that is the reason of hypocalcemia in a case of alkalosis. Right? So you have hypokalemia, you have hypomagnesemia, and you have low ionized calcium, which is bounded to your negatively charged albumin. Similarly, one organ is lungs. Whenever you have acidosis, you have increased protons or increased hydrogen ions. That's a potent stimulator to your brain to increase your respiratory drive. So you have tachypnea. You have tachypnea. Your work of breathing is more. So a person who is persistently acidotic will be respiring heavily and fast. So that can give rise to respiratory fatigue and eventually respiratory failure. So you have potential for respiratory failure. The opposite applies for alkalosis. The respiratory drive is less. If your respiratory drive is less, what could happen? You can have hypoxia. If your respiratory drive is less, obviously you will retain CO2, but you will not be able to get enough of oxygen, so you will have hypoxia. So these are the reasons why internists and doctors should know about acidosis and alkalosis in detail. Now we come to some major equation which will be used frequently in our lectures, that is Henderson-Hasselbalch equation. It's a difficult equation. It says that pH is not only dependent on hydrogen ions but also on PCO2 and bicarb. So pH is equal to pKa log HCO3 concentration divided by partial pressure of carbon dioxide. HCO3 is in milliequivalents per liter. Now we cannot apply this equation every time we interpret an ABG or a compensatory mechanism. So what we do is we modify it. We remove pH and pK and log. So it becomes a easy modified HH equation, that pH is directly proportional to your bicarb concentration but inversely proportional to your PCO2. This is not a real equation. This is an equation for understanding, right? We will not be using pK and log anywhere in our lectures. We will be using this equation only, that our pH is directly proportional to the bicarb and inversely proportional to the partial pressure of CO2 in blood. So we have three factors now which will be influencing acidosis and alkalosis. It is hydrogen ion, bicarb and PCO2, right? Now we'll touch metabolic acidosis. Metabolic acidosis. So we use our HH equation. pH equals to HCO3 divided by partial pressure of CO2. Acidosis means pH is decreasing. pH is going down. Suppose I keep my PCO2 constant. So what should go down? HCO3. If I decrease my numerator, if I keep PCO2 normal, pH will fall. So indirectly it means that metabolic acidosis is either an increase in hydrogen ion concentration or a decrease in bicarbonate. Either of this. You're getting it? If I keep my PCO2 normal in my HH equation, my pH will only fall if my bicarb concentration goes down. So this is the basis of metabolic acidosis, right? So what are the causes? The causes of metabolic acidosis can be remembered by a mnemonic known as mudpiles. You must have heard this. Mudpiles. M is methanol. Methanol ingestion or methanol poisoning. U is uremia. D is diabetic ketoacidosis. P is propylene glycol. Propylene glycol, antifreeze, which is used in our cars. I is isoniazid, the anti-tuberculous drug, right? Then you have lactic acidosis. Lactic acidosis. Right? Then you have ethylene glycol. And lastly, you have salicylate, your aspirin. So these are the most important causes for your metabolic acidosis. Now when we talk of metabolic acidosis, we are talking of high anion gap or a normal anion gap metabolic acidosis. So mudpiles is basically mnemonic for high anion gap. What do you mean by anion gap? Anion gap is we take sodium, which is a predominant extracellular cation, and we subtract chloride and bicarbonate from it. So this is my anion gap. The normal anion gap is 9 plus minus 3. So anything above than 12 is high anion gap metabolic acidosis or hagma. Anything above is hagma. Anything below or equal to 12 is nagma, normal anion gap metabolic acidosis. Right? So examples for hagma is mudpiles. So what is normal anion gap metabolic acidosis is nagma. We have causes like nagma. The first would be hyperchloridemia. Hyperchloridemia means you are infusing lots and lots of normal saline to a patient. You will produce normal anion gap metabolic acidosis in that patient. Second is hyperalimentation. That means you are infusing TPN to a patient. So that patient can produce normal anion gap metabolic acidosis. Second is acetazolamide and some other drugs. Acetazolamide, ACE inhibitors, angiotensin receptor blockers, cyclosporin, topiramate. So these are the drugs which are implicated in development of nagma. Third is renal tubular acidosis, RTA. RTA can be of two types, low potassium RTA or high potassium RTA. Low potassium RTA can be distal or proximal. Proximal is type 2, distal is type 1. So in both type 1 and type 2 you have normal anion gap metabolic acidosis, but you have hypokalemia. In acidosis you are having hypokalemia. In acidosis you tend to have hyperkalemia. So RTA type 1, type 2 will have hypokalemia. Increased potassium RTA will be type 4. Fourth will be diarrhea. Fourth will be diarrhea. Fifth will be you have your ureter which is joined to your GI tract. Say for example your ureter is joined surgically to your sigmoid colon. Ureterosigmoid anastomosis is there for any surgical reason. Right? Sixth will be pancreatic fistula. Pancreatic fistula. You lose lots and lots of bicarbonate in your pancreatic fluid when there is a fistula. Right? So the mnemonic for nagma can be hardup. HARDUP. So mnemonic for hagma is mudpiles, and mnemonic for nagma is hardup. Hyperchloridemia, hyperalimentation, acetazolamide and different drugs, renal tubular acidosis, diarrhea. You have a connection between ureter and GI tract, or you have pancreatic fistula. Right, so this is about metabolic acidosis. Now we touch metabolic alkalosis. In metabolic alkalosis, again we apply our HH equation, that pH is equal to HCO3 by PCO2. Sorry, metabolic alkalosis. So I am keeping my PCO2 constant. So what is increasing? HCO3. So either there is absolute decrease in the concentration of proton or H ions, or there is an increase in bicarbonate, which will increase the pH. Right? So one thing which you now keep it in your mind, that whenever there is a metabolic problem, pH and HCO3 moves simultaneously in the same direction. They'll both go up, or they will go both down whenever there is a metabolic problem. The opposite is true for respiratory. In respiratory, pH moves in one direction and PCO2 moves in exactly opposite direction. Right? So what are the causes of metabolic alkalosis? So the mnemonic is vomit. V for vomiting. You are losing lots of hydrochloric acid, H ions, in your vomitus. When you lose your H ions, the outcome is metabolic alkalosis. O is overcorrection on vent. Overcorrection of someone who is on vent. Probably patient is on ventilation for metabolic or respiratory acidosis, and you have overcorrected it. So you bring in metabolic alkalosis to that patient. Mineralocorticoid excess. Mineralocorticoid excess. The main example is Conn syndrome. Conn syndrome. I is iatrogenic. Iatrogenic. Say for example, I have a patient whom I want to give a contrast for a CT scan. That patient has high risk for development of CIN, contrast induced nephropathy. So we prophylactically use sodium bicarbonate, right? Or you have patient who has profound renal failure, CKD. In CKD we prophylactically use sodium bicarbonate tablets. So in that case, patient may land up into metabolic alkalosis. T is total volume loss. Means patient who has profound bled, either GI or traumatic bleeding, he may land up into metabolic alkalosis. Or someone who is taking diuretics, so he will lose lot of H ions in the urine. Someone who is taking laxatives, so in laxative abuse you are going to washroom very frequently, so you lose salts from your poop. So total volume loss either by blood or by use of diuretic and overuse of laxative can lead to metabolic alkalosis. Now we come to respiratory acidosis. Respiratory acidosis. So the same equation, pH equals to HCO3 divided by PCO2. So now I keep my HCO3 constant. So in respiratory acidosis, what's happening? If pH is going down, PCO2 has to go up. So any phenomena which increases the partial pressure of carbon dioxide with a normal HCO3 will result into respiratory acidosis. Right? So what are the causes? The causes are CNS depression for any reason. You can have a patient who is profoundly intoxicated or who has taken some high dose of benzodiazepines, right? So anything which depresses your CNS profoundly will lead to decrease in the respiratory drive. You have decreased respiratory drive, your ventilation decreases. Your ventilation decreases, your carbon dioxide goes up into your blood, because the production of carbon dioxide is at the cellular level, right? Second is you have some problem with your nerves, polyneuritis. polyneuropathy, wherein the drive is there but it doesn't go through your diaphragm. So you have polyneuritis. You have problems at neuromuscular junction. Again, you will land up into respiratory acidosis. You have myopathies. You have suppose myasthenia gravis, say for example, right? So whenever a patient in myasthenia gravis goes into crisis, he lands up into respiratory failure and respiratory acidosis, right? Then you have chronic obstructive lung diseases, cold. Any obstruction will impair the gas exchange. So you will again have high CO2 levels and patient will land up into respiratory acidosis. Now we come to respiratory alkalosis. Again the same equation, pH equals to HCO3 divided by PCO2. My HCO3 is constant. Now pH has to go up in alkalosis. So what should go down? CO2. Anything which causes less production of CO2 or lesser CO2 concentration in my extracellular fluid or blood will result into respiratory alkalosis. So what are the causes? So anyone who has CNS hyperactivity, say for example you have fever, so you will hyperventilate. You have pain, you will hyperventilate. You have anxiety, you will hyperventilate. You hyperventilate, you wash out your CO2, you have respiratory alkalosis. You have high dose of salicylates, you take high amounts of aspirin, so you can cause respiratory alkalosis. You can have sepsis, which increases your central respiratory drive, so you may land up into respiratory alkalosis. Suppose for any reason you have hypoxemia. For any reason you have hypoxemia. Say for example you have pneumonia. So your PO2 goes down. So what your body will try to do? It will increase your respiratory drive to compensate the lack of oxygen. So once the lack of oxygen is compensated, what will happen to your PCO2? The partial pressure of PCO2 will go down. Suppose you have pulmonary embolism or you have pulmonary edema. In all these conditions, you have hypoxemia, and this is a drive to increase your ventilation. The increase in ventilation will compensate for hypoxemia, but it will eventually cause respiratory alkalosis because of CO2 washout. Correct? So we'll stop here and we'll meet in the next lecture.